For the last panel, I chose three individuals, none of whom I had ever met before today and yesterday, to put them in a difficult and challenging position to help us sort out what we've learned today. And of course, that's not very much unlike me whatsoever. And I chose these three individuals because I wanted each of them in their own way to try to represent the constituency that they are part of, to think through the question of, given what we've heard here today, what are the challenges that they and their constituency will face going forward. So let me introduce to you the three folks that I've asked to do that. One is Marianne Lindeblad. She's now the Assistant Secretary of Aging and Disability Services for the state of Washington. Colloquially, I call her the Washington State Medicaid Director. The other is Flo Stein. Let's see, Flo, your title is Chief of Community Policy Management of the Division of Mental Health, Developmental Disabilities, and Substance Abuse Services for the state of North Carolina. Flo is my single state agency head, and that's what she's representing here today. And the last is Judge Bill Dressel. Bill is the president of the National Judicial College, and the constituency I'm asking him to represent today is all of the discussion we've heard about the role of the legal system and the role of the judiciary. So having framed that challenge, I think, Flo, you're sitting next to where I'm about to sit, so we're going to start with you.
Well, thank you. Thank you very much for this opportunity. I think that these kind of conversations are absolutely critical. We have to learn each other's systems. We have to learn the language and all the techniques and tools that we could put together to make this new opportunity work for consumers of our services or clients or detainees. See, we have lots of names for these individuals. I also want to acknowledge that I'm proud to be the president of the National Association of State Alcohol and Drug Program Directors, and you've met the two other SSAs that are here that are part of that organization, Raquel Mason-Jeffers, who asked that parity question, and Michael Botticelli in the back, who is our pioneer in health reform from the state of Massachusetts, who asked that question about carve-in and carve-out. And also our staff, Rob Morrison and Michelle Durst, who really help the states move through these kinds of transitions, providing us information and getting us to talk and share with each other. So that's one of the things that we have to do. We have to get up to speed. We have to understand. We have to represent our constituents to our governors, to our state legislatures. And we have to, while we're doing all the regular things we do every day, we have to get involved in health reform and make sure people with addiction and mental health disorders are able to access these systems, become enrolled effectively without too much hassle, and change our provider system to be ready to perform. We had a similar conversation. Melody was involved in that one too, and maybe probably in Albuquerque about 15 years ago when we did health reform the last time, and we said, oh my gosh, you know, the benefit isn't going to be adequate for our consumers in the justice system. It's not going to be enough, there's not going to be enough duration or intensity, and we know that effective practice for folks in the system that we are interfacing with are not going to be able to make it, and we're right back in the same spot. And so this is going to be my pitch for why any of you who can help us in the states hang on to our block grants. It is those block grants that allow us to do the infrastructure and support of this kind of initiative, because we in North Carolina have an integrated Medicaid state benefit. We've had it for 5 or 6 years. We do everything together with Medicaid. All our providers bill fee-for-service or are in managed care organizations. So they've sort of made this transition. But what cannot be supported in a benefit structure like we're going to move to, an insurance benefit structure, is all the pieces that hold these systems together. So if you can only have one case manager, for instance, in Medicaid, well, you're not going to have specialized care coordinators all over the place like we use now. We have a statewide task system. We have tasks available to the courts in all 100 counties, every judicial district. We work with the court to make sure people get in and out of treatment as necessary. We do CIT, we do jail diversion, both pre and post booking. All those things are paid for in a different way because they are not billable in the traditional sense of an insurance plan. So as we're getting ready, we want to make sure all the investment that we have made in our partnership between public mental health and substance use treatment with the justice system, the courts, jails, and corrections, that can be maintained while our consumers gain the benefit of the insurance coverage. It will be a benefit to them. Their health needs have been unattended to for years, even when they are in behavioral health treatment. And that should help them, and they will also have some choice. And I think that will greatly improve what we're offering them, because when they have no choice and they get forced into a particular program, if it's the exact right fit for them, if there is the right program, the right counselor, the right set of services, then they benefit. But so often the fit isn't really appropriate. And so then we sort of blame them when they don't succeed. So I think this is a great opportunity to improve what we do.
Mary Ann.
Thank you. Well, first, again, I want to thank you for the opportunity to be here today. This has been an incredibly valuable session for me personally, as I embark in a new position that I just took, and that has mental health and substance abuse as part of it. So it's been very, very interesting and very helpful. But I'm going to talk about it more from a larger Medicaid perspective, because that is also part of what I do also. And I think from the perspective of Medicaid, you know, 2014 in Medicaid speak is just around the corner. And I mean, it's just really facing us today. And we've got to start building the systems that we need in place now. We should have been probably starting a long time ago, but we have it today. We have health reform looming. We have, in our state, we're estimating somewhere between 400 and 450,000 or maybe more new eligibles potentially coming to systems. Now, they're not going to come all in one group. They will come in over time. And we do recognize that they're going to have more substance abuse, more mental health issues. That's expected, and from the folks we know that we've served in a general assistance population, and the folks that Dave Mancuso talked about earlier today have significant behavioral health issues. We're also a state that will be moving more towards managed care. We already have about 65% of our population in a managed care delivery system. We'll be putting more, our aged, blind, disabled, others in that delivery system. So these individuals, as they become eligible, they'll be eligible to go with a health plan. And so I think it's incumbent on us to start talking with health plans today and start building what that system needs to look like, what that integration conversation has to happen, and those health plans starting to have conversations with the counties, with the jails, with others to say, here's the kind of coordination we need, here's the conversation we need. We need adequate discharge planning. We need to know when somebody comes in. The jail needs to know who that person's provider is. That provider needs to know that person's been incarcerated, and help them get appointments, get back into the system. And if they're not linked with a health plan, get them eligible. And I think that's a ready-made system to help do that. So I think those are the kinds of things that we need to start focusing on at the Medicaid level, to really think about what does that system need to look like, and how do we get those community conversations going. I also think that this is a population that will have a harder time accessing services even if they have a health plan, even if they have a provider. How do we get them into services? And these are also the population that are most expensive. So those care coordinators also need to play a role in this, and they need to be assigned a care coordinator or a community health worker or some advocate or navigator that can help get them into a system, make sure they're going to their appointments. Just because they have the insurance doesn't mean they're going to use it. So we need to make sure, and that's the focus we've been doing in Washington, just in our high-cost populations, trying to link them with the provider, getting them into care, and with a focus particularly on folks with substance abuse and mental health issues. So just expanding that sort of work. I think there's also the whole provider capacity issue, and I appreciated the comment made earlier about looking at scope of practice, because if we're going to be prepared for 2014 and the onslaught of new eligibles, I mean, we have issues in our state already making that people who are eligible and in the system are having a hard time getting providers in certain parts of our state. So bringing on lots of additional people, if we don't start addressing that capacity issue and looking at things like scope, working people to the top of their license, provide care in teams, provide care in different sorts of ways than we have in the past, group visits. I mean, there's lots of things that can be done, but we have to start thinking about that and planning for it now. So I think Medicaid agencies in conjunction with a variety of other community stakeholders can really play a significant role in, I think, designing what a good system can look like. And I know that's something I'm going to go back and start to have that conversation with the health plans.
Before we get to you, Bill, I want to just back up just a second. I heard Linda talking in the session before about what she called making sure there was sufficient payment in terms of dollars in order to build capacity.
Yeah.
I think that, Dave, I'm going to keep coming back to your data, Dave, because I was so impressed by it. On the cost efficacy of that data speaks to that. I think there are also political challenges, unless I'm living in a world that's different than the one that I see out there, on being able, even if the feds are paying the bill for the first couple of years, on being able to envision a system with this very challenging population, because we know who these folks are, that we know that we get a good return on investment, to use business speak, when we make the investment. I guess the question I have both for you, Marianne, and for you, Flo, is will it be feasible for you to work within your state governance process to get rates that will be sufficient to have a sufficient provider supply to keep these folks in treatment? So when I ask Bill what he wants and he says, I don't ever want to see him again, will we be able to build that infrastructure? I think that's a question to both of you.
I think you're presenting an incredibly challenging issue, and particularly in our current economy and states all being very challenged with their budgets, that they're not going out and increasing provider fees. And in fact, in many states, they're reducing fees.
Right.
So the reality of that, I think, is going to be a big part of the challenge. The one thing I think that if you have a good accountable care delivery system, and I will say good, I want to emphasize that there are ways the cost offsets the savings, that you can invest your money differentially than Medicaid can currently do in a fee-for-service system as they have today, when they're just, buying widgets, so to speak. So if you have good contractors and have them looking at utilization, looking at better ways of delivering service, they have flexibility about what they pay providers differentially than, again, you might have in a fee-for-service world. I don't think that's all the answer. I do think that's going to be a continued pressure on states. With the ACA, there is increased reimbursement for primary care for a period of time. I think that will be helpful. It's when that increased federal match goes away, will states be able to maintain that level? And I think, again, unless the economy starts to significantly turn around, that's going to be harder and harder to do. So I think we're also going to have to prioritize who gets services and be able to try to offer services in the most cost-effective and efficient way. I think also, the conversation that was happening, was it a year or so ago, about financing community mental health centers in similar ways to community health centers so they get some additional revenue coming in. That's another idea that I hope continues to be out on the forefront, to look at some different revenue streams too. So.
Flo?
Well, I'll speak to it from maybe a provider perspective, and that is that in fee-for-service, rates are built off provider costs. So we want to pay what it costs the provider. So it kind of behooves a specialty provider who can demonstrate outcomes to be able to do that, show that, and then submit their cost funding for rate setting. In the managed environment, just as Marianne said, the purchaser can purchase from the person who's getting the outcomes they want, and the price can be negotiated. So the opportunity is there. notwithstanding the downward pressure that's going on right now because of state budget.
And the other thing I heard Marianne say is I heard her use the word accountable in terms of outcomes. And I think that one of the challenges for single state agencies has been trying to develop systems in which they can hold the folks that they contract with, or whether that's on a grant or a fee-for-service basis, accountable in terms of outcomes. Do you see anything changing that between now and 2014?
Around the accountability side.
On the single state agency side. On your side, I understand it more
Yeah.
easily. I think the question I'm asking is on flow. Do you think that there are things that you can do that... I told you this was going to be tough.
Well, what I'm hesitant to answer because I'm only answering for one state when I
Right.
answer this
Okay.
particular question, not all states. Although I think all states have been working toward more performance, more outcome-based systems. Not all states have been able to talk their legislatures into paying for performance, and that's where things really start improving. But we have a very robust outcome measurement system. It is, you can go online in our North Carolina system right now, and you can look at any provider. You can compare any provider to any other provider. The managing entity can look at all their providers and compare them on about 20 different outcomes. So you can use that in our state. I think that's what's going to be the hallmark of what happens going forward, because we're not going to be able to afford to hang on to providers who are not performing well. And
Can I just add one thing?
Yeah.
I do think that the whole pay-for-performance, performance-based contracting is clearly a direction that we're all going in. I think that's really important. It also behooves us to have the data systems to support that and making sure that we have good measures, we've defined them well, and then we have the data to support, especially if you're going to tie reimbursement to it. But I do think that's a direction that I know we're looking at that, and I'm sure other states are too.
Bill?
I just soon sit here not say anything and let them talk, because this, from a perspective, starting first with the judges and the court system, this is not our business. We need to get out of it. But is that going to happen? Probably not. So we're faced with the reality as a court system of really what is our role as far as finding out options, getting information so that we can act appropriately. I don't know if how many of you saw it, but this was in the article Pam and the others wrote, and it's really terrific from a standpoint. It's a continuum of justice intervention, and it really gives you a roadmap to talk about where decisions, can be made and should be made when somebody comes into the criminal justice system. And it all depends upon what information do you have, what kind of assessment. In the best of all worlds, what we need to do to get ready for 2014 as it comes about is put in place, starting with when the first contact is made, gathering information from the standpoint of the jails and the sheriffs, those people. They're going to want to have into place the mechanisms to be able for those people that are being held pre-adjudication that they can get reimbursement for the services. So they're going to have to make sure that the people that are providing the services are eligible to get reimbursed and do the billing and all the rest of it. So as you look at the criminal justice system, you need to look where the person is. In this continuum of care, I would at the end of it take out where it talks about prison, but insert jail, take out parole, put in probation. Because you've got a continuum up front. Whoever is doing the initial assessment when somebody comes into the system is going to have to ask different questions. They're going to come from a different point of view. That information needs to be shared on down the line so that at the end, when the probation picks it up, they are able to see that what you talked about, this continuum of care, actually does occur. We know that today, in many instances, it doesn't. Is there a role beyond that? You all heard Justice Stratton this morning talk about the efforts that she undertook in Ohio. And there are other places that do it. And I think in this room there's maybe about 4 judges that are here. And immediately came to mind as I was listening to Justice Stratton and thinking about the role of the judges. You know, I could sum up my remarks by taking that saying and changing it, the few, the proud, the judges. You know? And just leave it at that and move on. Should we take that authority to convene? We probably will have to. It will probably fall back in a lot of courts to convene the people, to bring them together and talk about, okay, what can we do from the very beginning? But seriously, this is not a justice issue. This is a public health, a community health issue. And we've got to somehow drive it back into that form. I have said many, many times in the past that shame on the courts for allowing us to become a point of entry, for really becoming the entity that is making these decisions. We know there will always be individuals that won't get the care and treatment unless there's something there. Okay, we'll accept that role. But this is a community-wide one, and as Justice Stratton and some others talk about, this is a time made for the courts to sit down, to initiate the discussion, to be made known, though, really, what do we need? And step back and allow the rest of you to come forward with the programs that will address the problems that we're dealing with. And the one thing I heard, Steve, also, it isn't just the mental health and the substance abuse. I mean, we got people coming in to the system with severe health issues. And we can't wait that they come in our doors for the first time to provide that care.
So, Bill, what I'm hearing you say is that you would go along with Justice Stratton's recipe of the judiciary as convener.
I think we need to play that role. I think Justice Stratton, if you understand the state of Ohio and how it's set up and the individual counties that are really have a lot of their own authority, and if you look at the lack of services in some areas that were there, she was trying to pick on the strong points, what they had that you could build on. You know, we're going back to strengths-based. You know, what do you have that it works for you in building on? At that time, it took somebody like her to do it. Not every state needs that. The type of intervention by the court or convening could be, who can really, when this person first comes in, ask some questions? If I could design a better world, I'd do away with booking. Have a booking. Have an assessment center. Someone comes in, they're assessed. And then they may leave. They may leave that facility hooked up with resources. They may end up being made a part of the system, but enter into agreement and divert them out. So you've got that all the way down to the end when the person does their sentence, that continuity has been put into place. So I think we need to be looking at more upfront, realistic assessment, and then as soon as possible making sure if there's care that's already being afforded that continues. And then if there has to be, if the person I think we're in different decisions about, do we really put somebody in a jail as a convicted person, or do we let them move into some other type of a situation? Seriously, I can't tell you the number of times, I was a judge for 22 years, I got a call. I've got somebody that they want to book in my jail. They need serious surgery. Can you give me something? I say, okay, release on overcognizance. And gee, the next place they were at the emergency room of the hospital. Wrong? Right. Maybe, but at least they got the services, and the county, you would have killed the small county's budget. So I think judges and the justice system are going to look to see how we can get the care, but get the care sooner.
And it's interesting, you know, Cochs did some work back in Indianapolis a while back, which has an arrestee processing center, similar to what you described, and the folks in that jail are not the misdemeanors, they're not the low-level pretrials. The folks in that jail are pretty much the folks that are likely to go to state prison.
Right.
Because they do that assessment up front in that arrestee processing center and try to build the linkage there. So I think that's a really interesting and excellent point. Questions from you all? I can't see, so I'm going to depend on you, Max.
No,
Good afternoon. My name is Bill Burrell. I'm a recovering practitioner. I'm formerly the Chief of Adult Probation Services for the New Jersey State Court System, and I'm also a member of the APPA, American Probation Parole Association Board of Directors. So some of my comments are on behalf of my colleagues in APPA, and others are just my own observations. Just first, I'm really excited to see public health issues and a public health perspective being pushed into the justice system and to some extent displacing our reliance on punishment. These are public health problems. We need to take an appropriate approach. Now, probation and parole represents a huge, and as far as I can tell, unaddressed population here today. 70% of the adults under correctional supervision are on probation and parole. It's over 5 million people. So somebody said you need volume to keep your places open Monday through Friday. Well, you want volume, come talk to us. We got the volume. But I realize that that may not be an issue we can deal with right now. We may need to start small and deal with the jail population. But probation has to be a player in this process. Okay, many offenders are sentenced to jail with the condition of followed by probation. So while they may lose their benefits while they're incarcerated in the local jail, they come back out on probation supervision. The judge talked about the information needs of decision-making of judges. Probation departments provide information at all stages of the process to help judges make those decisions. So they need to be involved in these discussions of what kind of information is needed. We talked a little bit about the veteran screening. Probation officers need to be brought up to date on that and know that that's an important question to be asking to be able to access the resources that are available. Many probation departments run pretrial services agencies, so they're doing interviews at the point of arrest, right after booking, to determine what information is needed for the judge to make the decision about release. So we need to be involved there. And then lastly, on page 16 in Pam's paper, I know Pam didn't write it, but it's the one she presented. So Pam, you're off the hook with this. But there's a chart there, and one of the columns is stakeholder leaders. And we were looking down the column there for stakeholder leaders, and probation and parole were not included at all.
Yeah, neither were we.
Yeah.
I think that's a serious omission. So, I'm glad to see this is being addressed, but I think this is a serious shortcoming in terms of not involving probation and parole as full partners in this process.
I appreciate that a lot, Bill, and I think that it is an untapped resource. In some of the work we were doing in Albuquerque, New Mexico, where they had a day reporting center for their probation and parolees coming out of their county jail, we've actually been working with them in setting up a substance abuse Suboxone clinic sponsored by Healthcare for the Homeless right there within that day reporting center to try to leverage probation and parole. I would suggest that the largest challenge in doing that is the diversity of probation and parole systems in the United States and the extent to which frequently counties do not control probation and parole. It's controlled through the state, and that there are issues, at least in my own experience, of how do you get those folks rowing their oar in the same direction when they feel as if they report to a different entity. And a lot of that really comes down to leadership, and again, I would suggest the role of judiciary. Bill?
Well, see, in the states where probation, and there's quite a few of them, work for the judiciary.
Right.
See, I came from that kind of state. And he's right. Probation really is a terrific partner from the very beginning. And they are not only just informing the court, but they are a point of contact for treatment, and they're doing a lot of planning and ongoing. And they can be the one who can notice, because we know that oftentimes people respond to different programs, either positively or negatively, and they can be the one to see that this is not the right program, that something else needed, or that they need to get in to a different mental health or some access. So probation is a terrific resource, and one that I look at as really being the glue that holds it together. So they need to understand what the impact of the act is, what information, because they should be the one to see that nobody gets terminated but just their benefits put on suspension. They can likewise plan to see that it gets activated and that they get back into the treatment, because it's absolutely ridiculous to have somebody come into the system, have this hiatus, maybe try to do something with them, put them back out, and nothing happens.
I'd just like to add that the reason these kind of conversations are so important is that the configuration of each of these parts of the system are different in every single state. So in North Carolina, where we have a state-operated judicial system, a state-operated correction, including probation parole system, then it is easy for us to work across state levels to make memorandum of agreement and push things down. But it's different in every single state. So we have to have this conversation each place.
Thank you. Other questions?
My name is Jim Pavley. I'm Executive Director of the Treatment Advocacy Center. We advocate for lowering the legal barriers to treatment for those with severe mental illness such as schizophrenia and bipolar. I must admit I'm ambivalent being here, yet I'm supportive of this effort at the same time. We advocate, of course, for treating people, trying to keep them out of the criminal justice system, and I know many of you feel that that is a logical goal to have. But I'm greatly heartened by the words that I've heard today, and especially by Judge Dressel, and I hope that in some way we can be supportive of this dialogue and this effort.
Thank you. Anyone else? Great. Okay. With that, I want to thank all of you very much. I think today has been an extremely productive and stimulating conversation, and I want to thank all of you for being part of it, as well as to acknowledge all of those of you who got to watch it on the internet. And again, I apologize that the room size was such that we couldn't fit any of you in. As our board chair, Julia Lear, mentioned in her introduction, the diversity of leaders in different fields represented here today speaks volumes to how important this topic is to all of us. Even with today's very full and very busy and very punctual agenda, we've only just scratched the surface on many of the areas that will obviously need much more attention going forward. And I want to ask each of you personally and organizationally for your active support in moving this dialogue on, by engaging your individual constituencies, by letting them know about the webcast of this conference, which will be archived on the Cochs website and will be available for the next several months. And we want to urge you, if you have an organization, to create a link to our website so your folks can watch this dialogue, can read the papers, can understand some of the challenges, so we can spread the word out on the hill we're all trying to climb together. As you notice, the papers discussed today and in your briefing kits are in draft form. Based on today's discussions, based on the work with the authors, based on the comments we hear, we hope to have them in final form shortly after the first of the year. At that point, we will circulate them back to you, and again, we're hoping that all of you will distribute them to your member organizations. Equally as important, I'm sure many of you today have made new connections or reconnections with contacts in fields other than your own. Part of what we've heard today is this is going to take a united effort and a collaborative effort to go forward. And I want to urge you, the reason we gave you the list of all the participants in your participant book is to urge you to use this as an opportunity to network outside your own silo so that we can begin to work together to attack and hopefully solve this solution that attaches all of us. Judge Dressel, your words might come true and you might not see them in your court. We at Cochs also want to know how we can keep you engaged in our ongoing policy and implementation discussion. What are the issues you feel that need further clarification? How would you like to participate? In the back of your books, you all have evaluation forms. I'd like you all to take 3 to 5 minutes before you leave to fill them out and leave them at the back. This is a really important resource for us in order to continue to be a resource for you. So many of you have come up to me today and thanked me today and thanked the Foundation today for this. It's really our listening to you that enables us to do this, and that evaluation form is a significant part of that. We will, at Cochs, continue to work diligently towards our goal of strengthening connectivity between correctional and community health, and we will be keeping you posted on our progress. What we want, and I think mostly what everyone in this room wants, is to keep the momentum going that we started today, and we obviously started quite a bit of momentum today. Once again, I want to thank you all very much for being here, for your attention to this issue. Together, we can establish stronger connectivity between jails and community health. We can improve public health, improve public safety, while protecting the public's investment in correctional health. It takes a lot of work, but we can all do it. Safe travels, and thank you all very much.